Good morning to everyone. Thank you for your punctuality. We are practically ready to begin day 2 of our workshop on continuous quality improvement to see the progress and the development of the HEARTS program during 2023, as well as the priorities for the coming year, 2024. Today, we are scheduled for a first section, a general session that will last until 11:30 in the morning, and then we will break up into different groups, the first of which will be the English-speaking Caribbean group that will be with Cynthia and Angelo. In the chat, we've shared the links for the members of that group to copy them. We sent them yesterday via email, but we are sharing them today through the chat room for persons that are assigned to each respective group. The second group is the Central American and Caribbean group, the Spanish-speaking group. So it'll be Mexico and the Spanish-speaking Caribbean countries where Natalia and I will be moderating. And then we have the last group moderated by Libardo and Andres. So please make sure you make a note of the respective links. And again, the sessions in the main room will be recorded for and will be available after the session, and they will be made available in Portuguese and in English. Additionally, if you have any academic questions, please access the section below the menu in the Q&A section. And prior to asking any questions or comments, please identify yourselves as well as the country you represent. With nothing further, I will yield the floor to Pedro. Thank you, Jenny. Good morning to everyone. I wanted to re-emphasize that we have a slightly different program today. We will have some group work. And given that we still have people joining the call, it's probable that we will repeat this information. But I remind everyone that if you ask a question or submit a comment through the chat, please identify yourselves as well as the country you represent. I was a little bit concerned, but we now have our colleagues from Cuba on the call with their presentation. So let me give you a brief summary of what happened yesterday. Yesterday was more for educational purposes on different methodologies being used in the Americas for continuous quality improvement. We presented a subset of tools that are being used at the present time and that we will be launching in the coming days. Now, when I say this, what I mean is that the official document will appear in the HEARTS website as well as the PAHO website. It will subsequently be available in Spanish and English. But this document will be available in Portuguese at some point in time. We will publish it in English and Spanish. And we've entitled this document a compendium of clinical tools that summarize all of the clinical tools that we use in the HEARTS program and that may be of interest to different healthcare teams, where we include the identification of manometers, how to validate them, how to properly take a patient's blood pressure, how to assess the different cardiovascular risk and what have you. So the idea is for this document to be available to anybody participating in the HEARTS program. And as we shall see today, as it's happening in various places, we've seen the academia joining these efforts and are using these materials. This is happening in Chile and Ecuador. Many of the documents being used in the HEARTS program are being used by academia as part of their training of students. So again, this is the compendium of clinical tools. And we also have the other document that relates to continuous quality improvement for healthcare provider teams. So this includes essential methodologies that you have access to, and these are directed or geared to the primary healthcare teams. One of the things that differentiates HEARTS from other activities we are conducting is that the main focus of the HEARTS program is the primary healthcare centers. So we are providing some notice here. There are 33 countries committed to implementing the HEARTS program, but more important than that, and those countries that are committed to implementing HEARTS, which is in and of itself an important fact, we have more than 4,000, I repeat, more than 4,000 primary healthcare centers that are implementing the HEARTS model. So I wanted to mention this and these two documents, and today we will be debuting a third document that will be for internal use. The idea is not to publish this, but the idea is to share this document with national authorities and with PAHO leadership, and it has to do with the progress assessment of the HEARTS program as based on the continuous quality improvement parameters. So that's basically what we talked about. Yesterday was primarily an informative session, and we did cover a broad subset of topics, and we included manometers, blood pressure cuffs, as well as the coursework that we have available online at PAHO through their website. I will be asking our team members to share the links to all of these different online courses that we have available for anybody interested in undertaking those classes. And we will be sharing the links for you to access that at your leisure. Again, today we have a very interesting program, and it's designed to share with all of you the experience undergone by 4 countries that are doing some outstanding work. And I'd like to place these 4 countries at the forefront so you can identify which countries have made significant improvements to their care models. These countries are Cuba, Dominican Republic, Santa Lucia, and El Salvador. Each one is focused on a different area. The idea was to focus on different areas and where these areas are providing outstanding improvement in different countries. And remember that one of the things that we've been promoting in the HEARTS program from the outset is that we establish this community of practice in which we can share what we learn. It'll be a space that will allow us to share case studies and examples so that other countries can learn from them. So we do have some champions in the region. One example of this is Chile. And they've not only been successful, but they've fostered the topic of clinical audits and the use of different drivers as part of the continuous quality improvement process that they've been undergoing. We will have a second moment that we have entitled HEARTS Implementation Performance Assessment Tools. And I always want to emphasize that this is an important message. HEARTS is not merely a silo or an isolated program, as some have tried to describe it. It is most definitely not that. But it's not enough for us to say it. It's not for us to appear to not be that, but rather we need to explain and tell the world why our approach is much more comprehensive. Something else that came up yesterday that is of extreme importance is that we have several dimensions of the problem, one of them being the healthcare system itself. Another dimension is that the healthcare providers, the people that provide healthcare services, and another dimension, which are the patients themselves. I wanted to state very clearly today is that Hearts seeks to change the manner in which the healthcare systems all over the Americas work to be able to provide better care to our patients and better efficiency for hypertensive patients as well as pre-existing cardiovascular patients. So these are conditions that in the aggregate represent half of the mortality that we see on this continent. Let me say that again, half of the mortality that we see in this continent, more than half of the lives that we lose are based on these issues. So with this introduction, I'd like to move on to our panel, our first panel, and I have the pleasure and the privilege of introducing our colleagues from Cuba. And I want to present Dr. Salvador Tamayo, who is the chief of the Non-Communicable Diseases Department from the Ministry of Health in Cuba. Angelo, I will yield the floor to you to continue with Salvador's introduction, and then we can get started. Thank you, Pedro. Yes, the Cuban colleagues are in the process of connecting to the call, but we will also introduce the other three countries that will also take part in this panel. So I'd like to ask Daniel Mola from the Dominican Republic to please open your camera. Good morning to you, Daniel. Pleasure to see you. Matias Villatoro from El Salvador. Thank you very much for joining us today. I'd like to also ask Shana Schilfberger from St. Lucia to join us. And open your camera. Good morning to you. So we have great practices that are being used by these countries. Cuba is still in the process of getting properly connected, but I wanted to highlight one of the elements that is extremely important that we wanted to share with the Hearts community. From Cuba, we have the issue of clinical audits. They've done some extensive work based on visits to healthcare facilities and focusing on practices. Then we have the calculation from the other country regarding the maturity index. St. Lucia, among other things, has been working on training and the implementation at different levels. And Shana will discuss the scope of all of the activities being conducted in there in El Salvador, along with the team from the Ministry of Health. We'll talk about the monitoring and assessment system and how this connects to the continuous quality improvement focus. All of these topics are extremely relevant and important. We see now that the Cuban team members have already joined us, and they will talk to us about the audits. If you will allow me, I'd like to ask Dr. Daniel Mola to discuss some of the work that they've been doing on the maturity rate. We have Salvador Diaz now. Excellent, just in time. Wonderful to see you, Salvador. And we also have the Cuban slides. Yes, we do have them. Good morning, Salvador. We are keenly interested in everything you have to say. Cuba was the first country that achieved 100% coverage of all their healthcare facilities. You heard me right. 100% of their healthcare facilities in Cuba are implementing Hearts, and they have a medical network that we're all very familiar with, especially you, Shana. They have a wonderful family medicine network. Shana went to school, and she's the director in St. Lucia of these healthcare medical services. And it was the first country, as I was saying, that achieved the 100% coverage in the implementation of the Hearts program in all of their facilities. So I'll yield the floor to you, Salvador. Good morning to you, Pedro, and good morning to all of the team members for Hearts. It's a real honor and privilege to be able to humbly present our experiences in Cuba. We just had our 50th anniversary of the first program ever developed in our country for hypertension control. And the results of that program to the date have not really met expectations. And that's why through the Hearts program, we sought to achieve a much more effective solution. And we looked to delve a lot more deeply into the issue related to hypertension as it relates to Cuba. And we are working with prevalence on the order of 37%. Next slide, please. Can you hear me, Pedro? Yes, we can hear you perfectly. Salvador, go ahead. If you could get closer to the microphone, it would be even better. Very well then. This represents more than 37% of prevalence of hypertension in Cuba, and we have more than 3 million Cubans that are trapped in this morass of hypertension. At present, we've diagnosed a little over 2 million of these patients. So with regard to the blood pressure, we decided to bet on hearts as a potential model that would help us solve these issues. And the background that was established during yesterday's activities and will also be highlighted today is that we need to reassess the model, the quality control model that we are using and transition from the traditional way of doing things to a new model. The decision that we made in 2022, between May of 2022 and May of this year, was to develop a model that had begun with three healthcare centers. And by the end of 2022, we had 22 healthcare centers. Even during the more dramatic stages of the COVID pandemic, we were able to expand the participation and commit to the application of the technology and the different activities related to hearts in more healthcare centers, more than 11,000 staff. And these are made up of basic healthcare teams and nursing staff, and they are the primary service providers for hypertension control services. Our goals correspond to the America's Hearts Program perspective. 80% of hypertensive patients documented, treated, and controlled. This is our goal that we are striving for with this entire deployment of intense work that we've undertaken in the last year in our country. Next slide, please. The increase in the number of centers that have been incorporated into hearts has reached 451. So our first level of care has undergone a number of challenges from the quality standpoint and the assurance of quality services derived from all of these procedures. There is a main issue here. You need to place quality at the forefront of anything you do in a healthcare center. And the commitment and the enforcement of these parameters and criteria in the service of continuous quality improvement is a foundational component of the entire process. So we've also established audits in our healthcare centers, more than 450 of them, at the very forefront of everything that we do. So we look as an audit, not as an external element, but more of a participation component that will allow us to maintain our continuous quality improvement. Next slide, please. With this circular cyclical process of planning, measuring, implementing, adjusting, which affords us the opportunity to continuously improve our quality. Throughout this year, we've conducted an audit that indicated that 57.3% of people with hypertension had been properly registered and treated, and 60% of those patients have their condition controlled. Now, this is a progress that we believe to be significant from the perspective of the quality involved, because quality needs to be aligned with the truth. Quality needs to be properly aligned with the reality of the processes and not the utopian view of how things should happen. This is where we demonstrate this reality expressed in a single graph. So in these 451 healthcare facilities, this is what we have. 139 of these during the first assessment, the first audit this year, did not report any progress. And this is feasible given the reality that we live day to day. But you can see here the different groupings, and you can see the centers that have a burgeoning self-assessment process. And we also see people that, or centers that are more advanced. This is a much smaller share of the total, but this is the process in the auditing that we have planned for the entire year. And during the second phase of the audits, we saw some improvement. By the closing of this year, we believe that we will have a great deal more perspective and a much greater commitment for the coming year, 2024. This continuous quality improvement management also includes 100% of healthcare centers in our country, and it's geared primarily towards data quality. We want to be able to measure everything that we do to be able to achieve some measure of progress. This is the main challenge that we face every day. This is a bold step that we took to include all of the healthcare facilities. The identification and problem solving at a higher quality in all healthcare facilities. There was insufficient management based on different traditional techniques, the use of sphygmomanometers are not recommended, any failures in measurements and non-compliance with the clinical criteria, among others. A last concept that relates to training as a consequence of these audits. And this allows us to engage in a continuous learning process. We need to consider that all healthcare systems are exposed to fluctuations, the incorporation of new actors. We need more support for resources. We need to uh, capitalize on the existence of online resources, given the importance of communication in today's day and age. This is extremely relevant for the implementation as well. I wanted to highlight this monograph that we worked on for a number of years, but we believe that we came up with a monograph that can be shared broadly for all tier one primary care providers. And this is another report that highlights the results of this implementation process that took place between May 2022 and May of this year, and that culminated in a national workshop that we had on March 17th of this year. And the horizon that we see for our commitment was clearly stated in that event. The implementation will be extremely important on our path to achieve maximum quality with our key stakeholders, given the commitment that Cuba has with the HEART program. We cannot allow for any drops in quality. We cannot allow anything to affect our quality management processes. If anything, we need to maintain our quality processes based on data and the proper management thereof. And this is basically all of the information that we've prepared for you all today. And we are happy to answer any questions through the chat. Very well, Salvador. Thank you very much. I wanted to emphasize a couple of points here taking advantage of Salvador's presence with us today. He is the director of the system in Cuba, and I wanted to highlight the policy that supported this undertaking for progress. We've seen that too many of our people die due to cardiovascular and diabetes diseases. And many times we see that cases may not have a cure available or it's too hard to treat these cases, but people are dying due to causes that can be overcome. And so we need to have a better understanding and assessment of the number of deaths and the mortality so that we can really understand the magnitude of the need and the urgency. So, if as a core essential objective to take this to the next level, we need to focus on the healthcare center, which is where all of these things are addressed. And getting back to another point that I wanted to make, the clinical audits and the continuous quality improvement process without patients and without the community is an incomplete exercise. In most systems, there's a hesitation to share quality data, and this needs to be changed to be able to do things in a better way. People have a right to know what level of quality our healthcare system has the capability of providing. Because these are the people that pay for the system, they are the builders of the system. That's the other part of this. When we have support, when we talk about universal access to healthcare, healthcare of sufficient quality, we require the stakeholders, all of the stakeholders to be involved. And this includes the patients. What do patients need for us to improve access, for us to improve the quality of the services that we offer? So the policy, public policy issues go hand in hand in all of this. That's why we thought that Cuba would be an excellent example, because even under very complex economic circumstances, not including COVID, this takes us to the next step that allows us to expand this vision. So thank you, Salvador, and I wanted to take advantage of this opportunity to extend greetings to those folks who are communicating through the chat. We have people from El Salvador, more people from El Salvador, and even more from El Salvador. We have folks from Suriname, Argentina, Panama, Mexico. So those of us that are here, we will know about. Those who are not, please convey our greetings to them. We have Guatemala, Chile, Bolivia, Peru. So we have a good number of countries represented. And I would like to propose the first exercise of today.
This will be the first exercise of the day for all the participating countries. Which are the three most important things that have been promoted in the health service through hearts? What policy has been enacted in your country? If there is anything at all that has changed because of this model, I am talking about the start point of the health system. Please, 1, 2, 3 points or practices that have changed with the implementation of hearts. And I will now give the floor to Angelo to present this from the Dominican Republic. Thank you. Thank you. I would like to welcome Dr. Daniel Mola from the Dominican Republic. He's the head of Monitoring and Evaluation, Division of Non-Communicable Diseases of the Ministry of Health. Daniel, the floor is yours. Please go ahead. One question. I have already sent my presentation. You can project that yourself or we can do it for you. Thank you. Can we help?
Yo voy a presentar, por favor.
No, I will be
Yo voy a
presenting.
presentar.
Yes, yes. Here we go. Please go ahead.
Momentito, por favor.
Please give me a minute.
Momentito.
Just a second, please. I would like to ask the other countries, St. Lucia and El Salvador, to please be prepared to project your slide. Please go ahead, Daniel. First of all, I would like to greet everybody. Good morning. I'd like to thank you for this opportunity to be able to share with the different countries the implementation of the HARS program. One of the advances in the Dominican Republic has been the fact that we started implementing this strategy in before 2020, but then in 2020 we advanced just a little bit, but we were able to go ahead and implement the new strategy, added to the fact that we had new authorities. And the authorities were presented with the strategies. They thought it was interesting, especially they consider the components for the decrease or cardiovascular disease. So under the past administration, we try to make sure that we achieve of the goals for implementation of HARTS. One important point in the Dominican Republic is the fact that we have a steering team at the national level to follow up on the implementation of the strategy at the national level, and they are also in charge of quality improvement. All the changes, whether they are positive or negative, that are visualized in the implementation of HARTS are channeled through different areas through the management group. But we have management groups at the regional level of the Ministry of Health, and also we have a central group. They are the ones in charge of implementing directly this HART strategy. Well, we had been implementing HARTS for 3 years, and so we decided to look at the maturity index to see how far we had advanced in the implementation of this strategy. And then the management team prepared a questionnaire. So this questionnaire contained the key elements for the drivers that we had discussed in the past meeting. We talked about the drivers as key elements to be able to take the HARTS initiative and the pressure control at the level of primary healthcare. So these drivers contain recommendations and objectives, and we score them. So our tool is based on the scoring system that was developed by PAHO. Once we prepared the tool, we decided to take as a random sample from 3 to 5 CPN for the regional services in accordance to the geographical extension of the region and the number of CPM that conform that. So in the Dominican Republic, we have 300 centers implementing this HART strategy. So we have a total of 30 services or centers in all of these provinces shown here. So why did we take a sample? Well, generally in primary health care units, in the regional services, depending on where they are, they have certain homogeneity in the advances. So as we will see later on, what was the final results of the summary of these drivers. So we reached the health centers and the management team, did several things at the same time. One group was in charge of the auditing of clinical charts. The other was in charge of interviewing health personnel. And then, even though we had not contemplated this in the drivers, but was important, we interviewed the patients and then we supervise the correct sampling and the correct measurements for our blood pressure. So we use the virtual field information given by PAHO. And then the only way that we could implement this was to take advantage of the supervision and see how the team was measuring blood pressure in the different users. So the interview to the patient was very important to us because here we saw how much was the patient aware, to what point was that patient aware of all of these measures, because we wanted the patients to be involved. And we asked the patients how had this care changed for that patient. So regularly, normally we didn't use to involve the patients in blood pressure measurements. So what the doctors said was that when they check blood pressure, they went through the second and third level of care, and they said that at the centers where HARTS was implemented, the patient himself or herself said, "You are not taking my blood pressure in the correct way." So the patient said, "They have taught me that the arm has to have a correct position." So the fact that the patients recognize the correct way to measure blood pressure is significant. And many doctors in some areas did not have this training. So that shows the implementation of HARTS. So these are the results of the implementation. We have 9 health regions. Each one of these regions has had homogeneous and the same measures. So we, in different regional centers, were able to show 3 different healthcare units at different levels. In some centers, the strategy was implemented. In others, the time of implementation was an intermediate level. And then the longer that the implementation had been going on, the better the values we received. So we have seen this for diagnosis and treatment and continuity of care. And for that reason, we have been able to evaluate performance. In some cases, implementation was very low, and the values were very low. And in others, we saw that implementation had a good maturity index. So here we have the performance index level. Here in performance, we see a difference in the regional services where the level of performance is low, and in other areas where you have a good maturity index for performance. And we identified several problems. In some areas, we saw levels that were lower than in others. What happened? There was a stock out of the main drugs that had been envisioned in the clinical pathway. Also, there were weaknesses in the correct use of the clinical pathway. Many times, the medical personnel was using a resource from the virtual campus for training. And then also, we reviewed the records of the patients that were controlled by the doctors. And we saw some better adherence to the clinical pathway in some medical records. So you have to really unlearn what you have learned in the past to be able to learn the new practices. And then, of course, we have to take into consideration the importance of the resources in the virtual course and the virtual courses. For instance, in the case of the health promoters and nursing staff, we saw that interviews were basically centered on doctors, but then not so much in the health promoters and nursing staff. So something really interesting that we have discussed in our meetings is that we found 3 health centers where there were 3 nurses, and they were empowered. They had the skills necessary, they had the training necessary for hearts. And those 3 nurses were able to comply with the clinical pathway without having a medical doctor on site. So the doctor, of course, went around supervising, but the reference to the clinical pathway is really important. In some cases, nurses cannot diagnose anything, but we notice that in the discussions that we have, the nurses have been able to comply with the clinical pathway, and that really surprised me. When it comes to education and training, when a doctor is not present, the nurses go and look for the care of that patient, appropriate care of the patient. So we still have a lot of health centers that we have centers where there's only a doctor who is an intern there. And after a year, the doctor goes away. So we have to consider the cardiovascular risk here. And then the centers do not have validated blood pressure cuffs. So for that reason, supervision of the centers is important. So what are the actions for the future? Related all the factors identified, we formulated some recommendations in writing. And we just developed a plan for improvement in these primary healthcare services. So we discovered that the primary healthcare service work was very good, but in some cases, these centers did not have validated blood pressure cuffs. But we found some high-level personnel there. So we actually center on the availability of drug programs for distribution to the population and to the different centers so that they wouldn't be lacking any medicines. Also, we consider all the points related to the clinical pathway. We, in some cases, saw that the clinical pathway had led to the update of all the strategies in monitoring and supervision. So practically, this is a milestone in the program for the implementation of the clinical pathway. And we had to really strengthen the clinical pathway element because it not only leads to the identification of what is not working well, but also it identifies the lack of training and the necessity to use this clinical pathway. For some health workers, it was easy to learn clinical pathway. We have to strengthen training. In the courses of the virtual campus of PAHO, we underline this point. In each health center, they should take the virtual courses offered by PAHO. Many people cannot go to the cities, and in many cases, we don't have the certificates available. But then, very rapidly, some people are able to take these virtual courses. The regional management team must guarantee a better participation of the health participation in the health system of non-medical personnel, especially in some areas where doctors are few in numbers. And then the responsibilities fall in the hands of nursing and promoting personnel. We have zone coordinators or area coordinators, and these people are not trained. So we realize that these area coordinators are the ones in charge of the day-to-day monitoring and supervision. And many times they have to travel from one place to the other. But now we have to consider this within the drivers to make sure that we comply with that. And then we have to strengthen management for the purchase or procurement of the blood pressure cuffs. But they have to be validated blood pressure cuff to make sure that we take adequate and accurate measures of blood pressure. So this is essential within primary health care. We have a lot of hypertensive and diabetic patients in primary health care, so we have to give priority to that area. Also, we want to work with monitoring through the different platforms, and we have our own platforms, but then if we join the PAHO platform, we're able to work and identify our weaknesses. And then if we use PAHO platform, once we have identified those weaknesses, in purposes of supervision, we can consider exactly what centers to supervise. When those centers know that they are supervised, there are always improvements. People say, well, yes, during the supervision, that is something good for us because we still have many questions. Thank you so much. Thank you so much, Daniel. This is very interesting, your advances in the Dominican Republic, how you have standardized this procedure. And I think in your presentation, the first thing is that the length and the depth of the auditing as a management tool, but also as a teaching tool. So you convene people so that they can participate. So this is a participatory process. I would like to insist upon the role of the patient, and I need to include the patient. Really, we have to consider the perspective of the patient, the perspective of the community, because that is very important for our work. The other thing is to make sure we have a local or in situ improvement plan, because different communities have different cultures, different conditions. And so that is another one of the points that we should consider. And then the role of nursing personnel, the role of nurses. I undoubtedly believe that the nursing personnel has a critical role in the implementation of HARTS, and also other health workers in some countries, for instance, community workers are important. And yes, we have to work with the pharmaceutical personnel because they could do a lot of things, because the pharmacies can do a lot of things. There are populations where people just go more to the pharmacy than to the medical system. I'm sorry. I'm sorry. I don't think I have my camera on. My apologies. What I was saying is that we are advancing, Daniel, But this all requires work. It all requires education of the community, a commitment of the health service and systems. But then we have to convey and disseminate this information to the health workers, and nothing better than the health center to be able to do this. So I would like, I ask some comments in the chat, and I ask for comments in the chat on how is hearts changing people. An important point also, I wanted to say that when we scored these services as to the number of problems, they said, well, yes, we can implement this change, but we need a process of empowerment. So this goes along with the process of empowerment too. Yes, nothing is carved in stone. So exactly, we have to see what do we do to improve things. If we don't have validated blood pressure cuffs, well, they are not validated. Well, let us accept what we have at hand. And let us ensure that people are trained through our courses. Let us ensure that we have supervision and proper training. But going back to the topic, I would like to say that the news today is sad, but there are countries that all the participating countries. I would like to share the news with all of you. Angelo, we have received the sad, very sad news that is the death of Dr. Carissa Etienne. She died of cardiovascular disease. Dr. Carissa Etienne was our past director. She was the director of PAHO for 10 years. Before, she was an assistant director at WHO and then assistant director at PAHO. She was a professional, totally committed to public health. And they have just told us that she has passed because she had a heart attack. And she directed this organization during the worst political crisis in PAHO, and then during the pandemic, the COVID-19 pandemic. And today, we have received the sad news of her passing. The director of PAHO, Dr. Jarbas Barbosa, has sent us a notice extending his condolences to all of Dr. Etienne's friends and colleagues. This is a very sad moment for the health in the Americas and for hearts. So the topic of cardiovascular disease, dear colleagues, is an enormous problem that can be avoidable. It's an enormous problem. We can do more things to avoid deaths. Our sincere sympathy and condolences to Dr. Etienne's family, her colleagues, and the family, and to everybody who met her. If you want to write your message of condolence in the chat, please go ahead. We will share your feelings with the rest of the colleagues at the organization here and in the Americas. Thank you, Angelo, for remembering Dr. Carissa Etienne, former director of PAHO for 10 years, and she left a deep mark. And we will remember her smile and with the best of memories. Thank you so much. After this moment, I am in shock. How can this happen? Well, let us continue with our work, being inspired by Carissa's commitment to public health, and to see what we can do better. How can we do things better? I will go to my next panelist, and then in the next break, we will be commenting on the reactions to the countries. Actually, the questions that I sent to the countries, what has heart changed in your country? So next one, Angelo Gamarra, please go ahead. Thanks, Pedro. Yes, we are very sad by the news of Dr. Carissa Etienne's passing. And the best thing we can honor, the best way we can honor her is to continue our work to the best possible. And I would like to introduce Shana Silferberg, Senior Medical Officer of Non-Communicable Diseases and General Clinical Services of the Ministry of Health of St. Lucia. Welcome, Shana. You have the floor.
Buenos días.
Thank you. Good morning.
Okay, so I'm just trying to share my screen. Okay, good morning. Can everybody see the screen?
Perfectamente.
Okay. Good morning, all. I'm deeply saddened by the news, and as Pedro said, it is a shock. I'm going to try to present as best I can. So this morning, we're looking at implementing HEARTS in the countries, and we're looking at improving the quality, quality improvement, of course, and we're looking at patient-centered care. And I have that we actually fighting against the many challenges. So I'm going to tell you a little bit about St. Lucia just by way of context. St. Lucia is a very small country. It's in the Caribbean. Our population is 182,000, well, 790, pretty, not many people there. The prevalence of hypertension was 28% in 2016, according to WHO. We did a survey in a representative sample of St. Lucians, a STEP survey in 2020, and our prevalence was 39.4%. Prevalence of diabetes is around 15%. We have implemented HEARTS in 20 wellness centers, and we're hoping to roll out HEARTS. We should have rolled out HEARTS in all of our centers, which are 34, but we had some challenges. So we'll have to do that in January. We already planned for January. One of the things that is interesting is that when we started in 2020, we had 5,000, a little less than 6,000 hypertensives in our register. And currently we have a little over 8,000 hypertensives. So we're seeing more people, which is good. So in terms of quality improvement, what are the strategies we've adopted? What have we learned that really works in St. Lucia? One of the things I thought very important was governance in terms of establishing who is going to be responsible for planning, for overseeing, and for actually monitoring what is done. I think if you don't do things like that, then you run the risk of not really knowing where you're going. And with HEARTS, we can't afford not to know where we're going. So we did have our steering committee from the very onset, our technical committee, which met more often at the onset. And those committees were governed by our terms of reference documents and everything. Another component of quality improvement we've noticed, well, we know that works, is the whole training and might I say retraining, because people forget. Evaluation and feedback, monitoring, which is super. You can't determine where you're going if you don't monitor what you're doing. Of course, one of the panelists mentioned it earlier on. We take very seriously our plan, do, study, act cycle, because that takes you places. It enables you to be able to actually improve what you're doing constantly. Knowledge sharing, we do quite a bit of that. Refocus, I call it, and also task shifting. And I'll explain a little more of that to you based on our situation in St. Lucia. And incentives. Incentives are very important when it comes to quality improvement. So in terms of training and retraining, why retraining? Because people forget what you've taught them initially, right? So you have to keep retraining. You have to keep reiterating that information so that it sticks. And as you do your plan to study act cycle, you realize that there's some things you would need to go back and target. So you can't be just train and just assume that everything is fine. So we have from the very beginning, from our launch, done our HEARTS online courses. We did have a log of everybody who did the HEARTS online courses, but we did think it was very important to get face-to-face training done. And one of the things we noticed that even when people did the online training, and especially in the situation of, like, let's say even our physicians, the online training would have been done to get what we call our continuous medical education, our CME credits, right? But then after that, they would not have necessarily been practicing what needed to be practiced. So the face-to-face training we found very effective because we were able to engage and get feedback and so on. And also to make it, how would I say, more culturally relevant. And even what we noticed for our what we call our community health aides, our health attendants, our nurses, there were aspects of the online training that we wanted to make very, very easy to understand and also relatable in the sense that they need to go back and train our patients, who are very important in terms of quality improvement. One of the other things we did in terms of training is we actually engage our staff and so on, and we produced documents, okay, our training material, our HEARTS procedural manual, which gives everybody an overview of HEARTS, what every member of your healthcare team's role is, and the clinical pathway. One of the things we do a lot in our trainings is look at the gaps from our audits and so on, and do targeted training so that we're not just training persons arbitrarily, but we're training them to be able to respond to what the issues are, to be able to correct those. So we establish core rules for every staff, and we ensure, for example, one of the things we do is, for example, a health aide. One may argue that a health aide does not need to know about why it is that patients have to come back after treatment is initiated. But we do that with our health aides because our health aides can now, knowing that information in a very simple way, knowing that information, be able to share it with the patient and be able to convince the patient why he or she needs to come back. And what we know is that our health aides would spend more time with the patients. They do what you call home visits. They're in the centers and so on, even when the physicians are out. So they would have engaged the patients more. So we need to be able to give very relevant information to them, so that they could share that and they themselves can be convinced. One of those things in terms of when we do training, face-to-face training, we actually ask persons to say what their role is in terms of the healthcare team, but what their role is in preserving the life of a patient or improving the quality of life of a patient. Okay, so we take it home. You use the whole sense that it's not cardiovascular disease and cardiovascular mortality is not something that's arbitrary. Every one of us gets impacted by it. And that, we ensure that persons are aware of that. As a healthcare worker, no matter what level you're at, you have that power to make the change. And so that is so during the training. We do a lot of reiteration of the evidence-based for HEARTS. Why is it that HEARTS is important? What is it just something else that we want you to do? Or, we bring that message home, which, well, we think is important. The barriers, of course, we look at because we understand that some of the barriers outside of the healthcare workers' purview. So we need to discuss those barriers and how we're going to actually target them. All of that is done through training because the feedback is very important. And one of the things we do is that training is actually inclusive. It's one thing to train your staff in the health centers or the wellness centers. It's another thing to have a patient go to another, to a private institution or the hospital and get treated differently. So everybody needs to be on the same page. So our trainings, we do what we call continuous medical education, and we involve the private sector, we involve our various levels of staff, pharmacists, etc. And we also do the hospitals. We also do programs on the radio and so on to make sure that persons are aware of heart. Our case discussions, we have a forum for our physicians. We have forums for our nurses. There are case discussions there. Persons discuss barriers, issues, etc. Those are pretty good. In terms of our training, to the right of the slide, I have just an indication of what formal trainings have been done. Of course, outside of that, we do smaller trainings. The funny thing is, we actually launched HEARTS in 2019, October 2019, and then we started implementing HEARTS during the pandemic. Of course, there were other priorities. I mean, that's understandable, but we had to continue pushing for HEARTS because especially during the pandemic, we understood how important it was to try to get persons controlled, to try to protect them in terms of cardiovascular disease, so that even the outcomes of COVID could be better. So we try, one of the things we want to do every year is around World Hypertension Day, have a CME. And what we've noticed is that when we look at the list of persons who come, we notice that we have very influential physicians, etc., from the private sector who continue to come to our CME. So that is pretty good. So in terms of monitoring in St. Lucia, all our wellness centers we have electronic health records. So one of the things we do through our training is ensure that persons understand how important it is to actually put the information in. Because if the information is not put in and put in correctly, then we cannot evaluate progress, etc., as we would like to do. And we do not have manpower. We do not have the human resources. In the Caribbean, especially, especially since COVID, we've lost quite a few of our nurses, and we continue to lose. So we need to be creative about how we get information, how we get our feedback, and who does what. So we rely quite a bit on our electronic health records to be able to give us information that we could take back to our staff and have discussions and see how we improve things. So one of the things we've done, we made changes to our reporting and the kind of dashboards that we pull up and so on through our health management information system. We've developed a registry, and we're using our registry to monitor, control, prescribing patterns, coverage, and we have what you call in-house developers. So we're able to make those changes and pull up what we want. Right now, we're trying to actually marry our system with the DHIS2 to even get better at that. So what you see at the top of the slide is basically that the coverage in 2023 from March to October has improved, and we're looking at the various wellness centers and what the control has been. It's not where we want it to be, of course, but it's actually better than it was. So this you're seeing now, we actually send out to our physicians. We have discussions on them. They have team meetings based on that. We can actually we could compare months for control. We could also compare years. So we compare, let's say, October 2023, the control in all of the centers, and pull out the HEART centers and be able to compare what it was the year before that and whether there have been improvements. Just by way of information, there has been improvement. But we'd be able to sit with those centers which are not doing well and look at, examine what the issues are and try to correct those through the technical committee and through our clinical committee. So in October 2020, we were just talking about that, how important it was to actually do your whole audit. We did what we called a rapid assessment when we just started implementation. We would have started in January of 2020. And in October, we looked at what we were doing right, what we were doing wrong, what the gaps were, etc. We got a consultant. He went through to pictures. He interviewed patients, etc. And we had a very good sense of where we were and what was lacking. And that has served. And to a lesser extent, we've done it with individual centers. We had staff that actually went out and they had a checklist in terms of audits. Like I said, we send our coverage and control rates back to our physicians and other healthcare workers. We share the prescribing methods. We look at who prescribes and how. In one of the slides, you're gonna see what I'm talking about. The clinical inertia, where that is actually discussed with individual physicians. And we do have, because we share, so in our trainings, we share our protocols and why, and with all the levels of staff, we explain the various reasons why. So why is it that a patient comes back in a month? Yeah. Why is it that we're not starting the whole 10 milligrams of amlodipine? And so because the other levels of staff know that, they would be able to comment and say, oh, but I noticed this patient has been on X for 3 months and he's not controlled, and why? And so that's the kind of engagement we want, because we want the healthcare team working as a team and not one individual just being able to do what he or she wants. We, of course, like I said, we look at the barriers to control. Sometimes they're actually outside of what the healthcare providers can do, and that's where our governance comes in, because our steering committee, which includes our chief medical officer, etc., would be able to help with correcting some of those issues. So, for example, the unavailability of our drugs, that would be, higher up. Of course, our patient non-adherence, that would be a lot of, behavior change, etc. Our lack of pharmacists, which continues to be a sore issue, that we actually have a plan that was developed to correct that. So this is just an example of prescribing patterns that is pulled out from our electronic health records. And that would have been from September. So that has increased in 2023. The value for 2023 would be increased. And one of the things we've wanted to do, based on the fact that we're training our physicians to actually evaluate our cardiovascular risk and prescribe as necessary, we monitor how our statin prescribing is actually increasing. So right now, that was done in September. Right now in November, the 2023 is actually at 9.89 thousand. So in terms of knowledge sharing and just, well, the argument is you can't give what you don't have. So our district medical officers are what we call our clinical leads, yeah, for the wellness center. And so one of the things we ensure is all of our district medical officers have to be HEART trained. We encourage them to do the online course. Of course, they do the online course because they get CME credits, which they need to re-register and to practice. But also we do face-to-face training with them. We engage our internists, our local internists, but we also engage our PAHO consultants and try to get training in for our doctors, and training based on what we think their needs are as we evaluate, how they perform. We send reminders to any new district medical officers so that they could do the HEART course, but also we ensure that they engaged in the face-to-face trainings. And I would have said why initially. What we've done, coming out of, we had a HEART workshop in May. Coming out of that, as we looked at quality improvement and so on, we had the establishment of a HEART clinical team. That clinical team is made up of 8 district medical officers, all HEART trained leaders who now can go through their various regions. We have 8 regions, and they are to engage not only their colleagues, because we have what we call continuing medical education that the doctors actually do with other doctors, and they get their continuing medical education credits, but they're also doing in-service training with the staff. Yeah, so they're learning because they need to go and make sure they're on top of the information, but they're also sharing that information. And as they share that information, they're monitoring, they have the information to monitor what is being done in the particular centers. Okay, so in terms of refocusing and task shifting, as I mentioned previously, we have an issue with our nurses. So we're losing nurses. And as Pedro would have said initially, if nurses and our non-physician healthcare workers, they're very, very important. We cannot, forget how important they are. And so we ensure that, yes, we're training our nurses, but we're training our community health aides and our community health workers as an integral part of our team. And so they're doing the blood pressure measurements. We ensuring that they have, there's a lot of reiteration of how to accurately measure the blood pressure, that the need to use validated monitors. Actually, all the sites, they're validated monitors in all the sites. And actually, if there aren't validated monitors, the health aides, etc., will be the first to complain because they've been taught that the validated monitors are necessary. We do, for them, we do actual, even if they do the virtual course, we do the face-to-face training and we let them practice on each other while we observe and so on, because we find that as you do things, well, not we find, the research says that as you do things, you remember them better. So that's one of the things we do. We make sure that we have, we give them very culturally relevant information. There's a context in St. Lucia where persons use a lot of herbal remedies, they have issues with drugs, and this and that. So we teach them all of those things while we do our training. There's the establishment and the reiteration of the workflows. What it is that is done during a clinic where you have hypertensives and diabetics. Who does what, etc. Because we find that those things allow persons to be able to stay and do what they're supposed to do. And of course, the follow-up of clients. We in St. Lucia, we have what we call family nurse practitioners who function similarly to physicians, so they could actually prescribe and titrate and so on. So we use them as well. To the right of the slide, I just wanted to look to show a pattern. So in 2019, our community health workers who are not nurses, we trained 21. In January, we trained 18. And let's go down to January 2023. What we did, we were deliberate about refresher training, and we pulled up our CHAs and we were deliberate about training them. So we train nurses and community health workers, but like I said, we're losing our nurses. But we train 42 out of the 91 persons present, right? In terms of nurses and health aides, we train 42 community health aides because we understand the value of having our health aides be able to do those things that will make a difference in hearts, in cardiovascular disease control and reduction of endpoints. Okay, so this is just an example of a workflow. This is, like I said, based on what we see, based on what we know the issues are, based on what's also in our implementation manuals, we develop, specific information for our clinics. So you see FNP is family nurse practitioner. So they would be where you see the DMO, who is a district medical officer. Okay. And we would insist on things like making sure the patient's bladder is empty, et cetera, and the counseling, as you may see. So in terms of incentives, when we're looking at quality improvement, incentives play a very vital role as well. We know that one of the things we've done during HEARTS implementation, and we noticed is award persons with clinics with the best clinic, the most improved, best hypertension control, the most staff trained, because you want training in both face-to-face and getting the virtual course done and getting the certificates. And what we've noticed is those sites who initially would have bought in prizes, they continue to do better. So just so you know. And it's really fun to see, One of the latest things we've done is we've given our physicians incentives. So we have physicians who work really hard in terms of trying to ensure that things happen in their clinics and so on. And as we understand the value of accurate blood pressure monitoring, repeating blood pressure readings if they're high, ensuring that audits are done in terms of how the staff are doing blood pressures. Our physicians are given, we have those physicians being given a validated monitor that they will go around with. They get to do the training, they get to recheck themselves and so on. And so that's an incentive because they have something that's given to them that they didn't have to get. But yeah, they now are catching the vision. So it's just one of those things. All right, so step by step, and the thing is done. Thank you.
Wow, Shanna, impresionante, ¿sí?
Wow, Shanna, that's really impressive. I think that Shanna has given us a master class in how to put together a program with all of the elements. Now, what is it that I'd like to underline here? Information, data. Without data, without information, we cannot run a program. I think this is a key element. Another key element, Shana, that I think you touched upon that's very important is that we need to provide feedback to the healthcare team. It's not just data that we collect and put on a drive somewhere. This is data that needs to be shared with other healthcare centers and shared with other healthcare personnel so that they themselves can improve their performance. Another very interesting and important topic is the surveillance of the prescription patterns. This is not something that we do on a routine basis, but if we're starting, we don't look at the patterns, then we won't know that in some cases, the patterns dictate that things need to change. And this is very important. And the fact that you are increasing the number of people that receive the training has allowed you in St. Lucia to treat more than 2,000 people that you didn't even have in your records. And I wanted to reiterate another figure, and I always like to provide context for this. Every time we increase by 1% the population control for hypertension, we can reduce up to 3% the mortality rate in that population. Again, for every 1% increase in control of hypertension, then the number or the rate of mortality for that population goes down by 3%. So we need to look at all of this, and we need to congratulate St. Lucia. Shanna, you are a true leader, and I always recommend you, and I always refer people to you because I want them to learn from you, because you can teach them what's happening. So I'm concerned that I don't see a lot of participation by the Caribbean countries in the chat. I don't know if this is a language problem or a translation problem. I don't know what's happening, but we have Abdullah, we have Belize and other countries that are sharing some information in the chat regarding what's happening in their countries. We also have opinions from Argentina, Chile, and Uruguay that are valuable to the teams. But I'm concerned that we haven't heard from Bolivia, Peru, Ecuador, or Venezuela. We haven't heard from them as to what's happening in their own countries. We haven't heard from El Salvador, Mexico, Panama, Cuba, Dominican Republic, and Guatemala. For example, or we have heard from those countries, but we haven't heard from Costa Rica, which is another country that's implementing HARTS. The question that I pose to everybody in the chat is, what's happening in your HARTS implementation? So we're running a little bit late, but we will catch up. Now we have our next presenter, the next country. Angelo, please, you have the floor. Yes, Pedro. The next presenter is from El Salvador, Dr. Matias Villatoro, coordinator of the Non-Communicable Diseases Division from the Ministry of Public Health in that country. Doctor, you have the floor.
Confirmando si el doctor Villatoro está conectado.
No tiene sonido, doctor.
No, there's no sound.
Villatoro tiene el micrófono cerrado.
Dr. Villatoro has his microphone in mute. Now, please go ahead. Good morning.
Sí, adelante, Matías Villatoro, por favor.
Please, Dr. Matias Villatoro, go ahead. Can you see my presentation? Yes, we can see it. Please go ahead. Thank you so much. First of all, I would like to extend my condolences to the family of Dr. Etienne. I had the opportunity to meet her when I was at PAHO, and I would like to thank you for this opportunity you have given us to present our strategy on the HEARTS program. We will be centering on monitoring and evaluation using this platform recommended by PAHO. This is a monitor and evaluation platform that is very transparent. And I would also like to take this opportunity to thank for the technical assistance we have received from PAHO. We have been able to implement the HEART strategy in El Salvador. It goes from the local to the central level and to the national health system, including all these, what we call the solidarity areas for health. Also, I would like to thank our staff for all the support that they have given us in this process of implementation. It has been a real fast process, especially when it comes to validated blood pressure cuffs. Our country is relatively small. However, the good news is that we have implemented HEARTS at the national level. We have 754 health settings and centers that have implemented this, and we had a four-phase implementation process. We are very grateful for the efforts of the local staff. So we will begin by saying that we started this initiative, we asked what it was, and then we managed to turn this into a strategy that is adapted and implemented in our country. And the other question that we ask, why do we have to implement HEARTS? What is the reason for implementing HEARTS? Well, we answer with the prevention of early mortality. As we see in this chart, we conducted an analysis of the prevalence of hypertension in accordance with the parameters set by WHO. And we saw here some values. Here we have circled 39.60% in red. And this shows the control prevalence of hypertension. The prevalence of controlled hypertension allowed us to work within the strategic framework of health in El Salvador. We have worked through the different development plans from 2019 to 2024, 2020 to 2030, and 2021 to 2021. And then within our priorities, we have incorporated the reduction of premature mortality and then the reduction of this mortality caused by chronic diseases, especially. And then we prepare a roadmap for the implementation of the HEART strategy. And we established an official commitment for the strategy in August of 2021, and we began to adapt this program to our country. We did not have any clinical pathway. We did not have any protocols. We do not have any validated blood pressure cuffs. And then doctors bought their own blood pressure cuffs. So there was no standardized system for validation of these cuffs. And then we couldn't tell whether the patients with high blood pressure were controlled or not. So based on that, we started considering the training of health personnel. We started training them not only in the clinical pathway, but also in monitoring and evaluating systems in our country. So in August of this year, at the national level, we have trained our health personnel in two components, in the component of the clinical management of hypertension and the non-drug treatment, and then the system of monitoring and evaluation. We set some goals that have been presented by other colleagues, diagnosis of hypertension, treatment, and control. And this was 80% across. So we have seen specifically this in our operational annual planning, where we have the drivers, and you can see in red the active detection of high blood pressure patients, those that have been detected and those that have been controlled. And then we have standardized protocols in our country to follow up this initiative. And then we have gone through the 8 steps of the implementation of quality evaluation and the implementation of the heart strategy recommended by PAHO. First of all, we had to form a multidisciplinary team or teams for management and coordination at the local level and at the central level. Then we diagnosed the needs to improve the resolutive capacity in technology, teams, devices, and then the blood pressure cuffs and drugs. Then we started planning, starting from diagnosis and the baseline, and we programmed the target population for the implementation of the different models in the health networks, in the implementation of the nominal registration system for non-communicable diseases and their complications. And for instance, metabolic and kidney diseases and the complications. And then we implemented the electronic registries and patient charts. Then we started theoretical and practical training. And to be able to implement HEARTS, we have to have a practice section, especially in the use of platform of monitoring and evaluation, to make sure that the personnel learns to use this platform not only for training our instructions, but also to conduct analysis. And then we started technical assistance with small groups to incorporate all of these systems. And then we had a monthly analysis of information through indicators of performance and outcomes. And then the last step was the quarterly evaluation and improvement of quality of information, as all of these translated into an improvement to make sure that people put this into practice. And so we started with our clinical pathway and how the 8 drivers recommended for the implementation of this strategy have been put into practice with the different elements. And this is one of the pathways that in a very short time will be available to all the health, throughout the health system, just to make sure what are our responsibilities, and we want to ensure the participation of the patients. And then we have this chart to make sure that we have a heart pillar and those are the coordinators, the protocols for treatment, drugs, etc. And so we gave a name to each one of these programs. We have a national coordinator, Dr. Patricia Erazo. We have the directors for treatment protocols, drugs, the different equipment for blood pressure cuff, and then education and training, follow-up and evaluation, and all of these are part of the team. And then step by step, we have implemented this process. We are following this to the letter for the National Plan for Implementation of the Hearts Initiative in El Salvador at the level of the Ministry of Health, and with the collaboration of the government of El Salvador. And then the private sector too, we have been able to incorporate or to add the universities to this process, and then the National Commission for the Study of Non-Communicable Diseases. All of these people have participated in the implementation. So we have used the modules recommended by WHO, and we are implementing them at the national level. This is 100% implemented in the first level of care, and we can see the results here. These are some examples in the different departments of the country where the system has been implemented. You will see the percentages here of health personnel that are trained in the proper way to take blood pressure. And then we keep on adding different health settings and centers, and then this will show an increase in the number of people trained. We see that in some cases where we have up to 95% of people trained, this means doctors, nurses, and other personnel. So we are updating this periodically. Here we see the results in training and evaluation. We see that 70% of the doctors have conducted and studied this program, 72% of nurses. And then, of course, throughout the system, 100% of the doctors have to really go through this training and education to be able to have their certificates. And then, from the basic health services to the upper services, we're able to implement this. 100% of our health centers have validated blood pressure cuffs, and this is a great achievement in our country. And we are taking advantage of different sources of financing existing in the country. And then we have joined the first level of care to buy this blood pressure equipment that has been already validated. So here you can see the exit surveys, the results of the exit surveys for the maturity index, and we have some challenges in the evaluation of cardiovascular risk, and especially when it comes to patients exposed at high risk. But we already have protocols for decision making, and we are already going from the red color to the orange color. And then we also have the protocol of standardized treatment. We still have some difficulties, especially in the intensification of treatment, especially in patients who are not controlled. And then that way we are able to confirm hypertension. So the integrated health system is a platform where we have an electronic patient chart for non-communicable diseases, and then we have a report page that allows us to have a nominal registration of all the patients by health establishment and health center to be able to follow them up. And this is the maturity index for implementations of the heart system, how we have been working on this platform. We see that we have gone from the beginning level of 7 to 10 points, and we have advanced right now, as you can see here, thanks to the support that we have had at the national level. So when we see the performance index for the implementation of hearts, we see a high performance 2.5. This changes, of course, depending on which health centers are entered in the information registry. But we can see here the results obtained with hypertensive patients. And now we have control of 80%, and the main challenge is to treat the hypertensive patients with high cardiovascular risk. Logically, there are here several comorbidities. And so we want to overcome this problem, and we have over 21% of coverage for patients in the heart system. We are detecting about 74% of our patients with hypertension, and that is an important effort. However, we have to keep on improving to reduce this cardiovascular risk and the mortality for cardiovascular disease. Here, I wanted to show you an example of an quality improvement plan. And this is based and framed in the Hearts Initiative. We have in December our next evaluation to be able to evaluate the first 5 phases to see what is the performance of all of these programs from now until 2024. Here, we have some of the activities regarding, first of all, the protocol for measuring blood pressure. We still don't have the validated, we didn't have the validated blood pressure cuffs in May of 2023, but now we do. But then now, in terms of cardiovascular risk, we have to make sure that the evaluation of cardiovascular disease risk is compulsory in all the local levels, and we have to have feedback mechanisms to make sure that we properly train the health personnel. If you have any questions or any comments, please send them to me. Thank you so much. Thank you. I think really this shows what we can do. Matthias, you didn't present today how we begin to observe prematurely a trend to the events that leads to cardiovascular mortality. You are really implementing this. El Salvador is now reaching 80% control, 80% control of hypertensive patients, and over 60, I believe 63%, I don't remember exactly, 63% of high risk of cardiovascular disease has really lower blood pressure. What do we have to underline? Systematization of the process, the institutionalization of the process, the management of the data, thanks to the patient's clinical history, and then having 100% of validated blood pressure cuffs. So this guarantees good diagnosis and good follow-up of hypertensive patients. I do not have any doubts. It is clear that the best example, comprehensive example that we have in the entire region is El Salvador, the deployment of all the initiative in all the components. So Matthias, I want to extend my sincere congratulations to you, and I would like to ask the people who want to learn how to deploy this system, invite Matthias to present what El Salvador is doing, because this is really impressive. These are impressive results. Congratulations to El Salvador. And now we are ready for the next presentation. Thank you so much, Matias. Thank you, Salvador. Thank you, Ghana. Thank you, Dominican Republic. Daniel has left. He had to go to another meeting. Congratulations to all the panelists, because your countries are excellent examples of what a country can do with the HEARTS vision. But remember, HEARTS has multiple components. That means that the levels of control of blood pressure are not going to improve by a miracle, by the Holy Spirit. So the Holy Spirit helps, but it's not enough to control hypertension. So we have to deploy a group of actions, concrete in nature, in multiple areas and dimensions of the country. So now I have the pleasure of presenting our results of what we have called a critical performance appraisal. So now I would like to introduce Angelo Gamarra and introduce our next speaker. Angelo? Thank you, Pedro. Yes, I would like to thank you, thanks to Cuba, the Dominican Republic, El Salvador, and St. Lucia. And now we will go to the presentation of the performance appraisal new results. I'll give the floor to Natalia Parra. She's part of the regional team of HEARTS at PAHO. Hello there. It is a pleasure to be here with you, and for me, it is very moving to see all of the things that have been presented. I will summarize the last report that we have, but I would like to ask Libardo to please share the presentation. I don't know if you're seeing it right now. Thank you, perfect. So if you can go to the next one, please. Yes, just to let you know, yes, that we will have a report of the heat map implementation. Let me tell you, it's a beautiful report. I'd like to say that. Here, just to summarize what we have already mentioned in a very consistent way yesterday and today. This is where we are. And then we have to ask, where do we want to be? If we have gaps, if the red figure shows the access gaps and the green ones are the quality gaps, we need to move all the people at least 50% so that they reach the dark green, people who have been controlled and treated. But then we say 80%, 80%, 80%. And so that all of the 50%, next one, the next one, please. Thank you, Pedro. Thank you for letting me know. So next one, please. Okay, go back. We know how to reach this point. The drivers are the key at the level of the health teams. We already know that. And I was really, really amazed when my colleague of Cuba said that you have to send in the reality of the process and not the utopic situation. That is wonderful. That made me think how to interpret this phrase. So if the topic and the target is to improve health services, we need to know how, when, where, and who. So that's when we start talking about hypertension control drivers. So we are thinking of whether they should be implemented, these drivers should be implemented within the health system. What is the role of the countries when they want to drive and foster the control drivers implementation in their own territory? So next one, please. Pedro mentioned yesterday the necessary attributes to determine the success of a hypertension control program. Here we have 9 domains, structure domains, and process domains, and outcome domains. So this is the way we facilitate the drivers implementation. This is our map, the different domains and areas that are required to be able to reach our goal. So these domains are the ones that determine the evaluation program, and that's the heat map center. So here, what I would like to emphasize is how should we read the heat map? So this chart allows us to do 2 things very fast. And then we go through the structure domains to see what has been the impact in the impact domains. It's at the end. Coverage and control and scale up. So we see regional patterns and areas in which we still need to close the gaps. And then there we have the opportunity to have advances to attain our objectives. At the same time, we can value the fact that the countries have a more advanced process and others that are in the beginning process. And then the countries individually can determine whether which are the domains in which there's opportunity for advancement to be able to attain better goals in control and scale up. So the most important are, of course, are the control ones. So if we begin by details, I would like to mention a few topics and a few countries and a few advances that need to be underlined. So for instance, in medicines, 15 countries have updated their list of medicines. Several more countries have updated their essential drug medicines, and now they include several that were not included before. So here, the Dominican Republic has information that is very valuable when you read the monthly report. And I would like to thank all of you for sharing the information. It is fantastic to be able to read a monthly report and to see how a country has taken the time to have clinical audits and to document the fact that that work has been given enough information to procure different drugs, not based on a historical reference, but on the point where they want to go. And so this future vision has really set the goal for 2024, not based on historical precedent, but based on where we want to be in the future. We shared that yesterday. And so in terms of drugs, in 2019, 2 pathways have been created, one to satisfy the needs to access to drugs available at the time, and the second one with the vision of where we want to go. Finally, this year, we have been able to reach, actually procure these drugs and to open the way for a second clinical pathway. I would like to mention the example of St. Lucia, and then they have a high level and scoring in drug use, but also they have a ministerial decree for the provision of drugs free of charge. And then to make sure that this is all registered in the health information in the country. So this type of information is really fantastic to have, because it's wonderful to see how the countries are really working in different areas to be able to have great advances and more impact. And then the clinical pathway, 15 countries have clinical pathways, or 20 countries have, and 15 of them are very good quality. And we have some countries that have not advanced so much in this domain in terms of scoring. but we cannot assume that the countries that are, for instance, Granada, Turks and Caicos, Uruguay, they are advances. They are doing all the coordination work that is necessary to be able to have clinical pathways for implementation in the near future. Also, we see the case of Bermuda. Bermuda approved clinical pathways in record time, and now it is in the process of expansion. And then going now to another positive development in scale up, we see 7 countries this year. There are additional, so we have 33 countries committed to hearts at the national level. In terms of scale up goals, 7 have scaled up to all the healthcare processes. 7 countries have scaled up to 80% or more of all the primary healthcare interventions in the country. And then 11 of them are projected for 2024. So you can imagine what is already clear through the presentations. We are really imagining the impact that clinical pathways have if they are implemented in all the high quality services in the country and in all the regions, and the impact that this would have in terms of standardization and quality. And then thinking of those terms, we have a really important synergy among these domains. So when we have advances, but we need to improve, we have that as far as regulation of blood pressure cuffs, this is not up to par. So this is something in which we can say, yes, there has been some awareness effort to be able to advance in this field. And also we have seen important examples of what to do to make sure that we improve the supply and the number of validated blood pressure cuffs in the region without having the regulatory framework.
Que al mismo tiempo promueven respuesta de parte de los proveedores para proveer materiales que se adhieren a los requerimientos de validación. Chile también ahora requiere que todos los manómetros validados del país que estén validados, sí se van a comprar con fondos públicos, y hay varios países como son Ecuador y Perú que recientemente también han invertido en estos devices, en estas herramientas, que son absolutamente necesarias, pero que requieren de un planeamiento fiscal y una inversión periódica. Ok, pasando a educación y entrenamiento.
Moving on to education and training, in these areas, the countries show a correlation in the progress related to the level in which, or the degree in which they started implementing the HEARTS program. This will be very helpful to allow the development of the specialized teams, and there's a lot of room for growth in terms of progress there. This is important because the education and training program will allow for it, but this is not just affected by the regulatory framework, but there are additional cultural elements that the region really needs to look at in a different way as to the role of the healthcare providers. Matias mentioned that they are truly motivated and feel the urgency to not be associated with this orange-colored status, and they want to move to green status as soon as possible. The point here is that the healthcare teams, all of the members of the team, need to be personally vested in this, and this needs to be reflected not just in this slide, but in the data being generated by the healthcare facilities, and they need to be active participants in the understanding through the analysis of the data what their status is as far as this process is concerned, and in terms of the quality of services that they are providing to their patient population. In terms of the drivers, we've seen excellent examples in terms of the execution of various studies, external studies that have been done to address the gaps and how to face them. We have the Dominican Republic case, as well as Chile and Peru. El Salvador is one of the countries where this data collection related to drivers to assess how the drivers are performing at the healthcare facility level. This is important because this is a gap that needs to be emphasized to adopt a culture of data collection to understand what direction they are traveling on and how to get to their prescribed destination. This is applicable to the entire healthcare team. In terms of coverage and control, you can see that the region is not performing in the manner in which we would like. There's still a lot of work to be done, but we can see a couple of things. One, that there is a well-known problem of access and quality. So we also have to improve the implementation of the monitoring and evaluation process. This is the most critical element. And lastly, when we move to the governance issue, we can see that this is performing pretty well, but when we start to look at each country individually, the impact not just in the final score, but rather in the control and coverage ranges, I have to emphasize the most clear-cut case in El Salvador. So when the 9 domains of structure and process are implemented at the same time, this is positively reflected in the results. And when a country understands that they're not where they need to be in coverage and control, then the leadership can try to assess where the gaps exist and what they can do to bridge those gaps and bring about the required impact, and in this way improve the coverage and control rates. Moving on to the next slide. I think many of these elements have already been discussed, but I did want to reiterate that the idea would be to incorporate all of these measures at the same time as much as possible, and that's what will bring about the biggest impact. Lastly, I'd like to mention something that is very positive, notwithstanding that we are not at the level where we would like to be in terms of the reporting and assessment. 95% of the centers that are implementing HARTS are reporting data, which is a fantastic outcome. But we do see quality gaps and IT or information gaps in some of the facilities. And we need to try to improve not only the quality of the reporting, but also of the data. Moving on to the next slide. Lastly, here, I wanted to mention that in the report, you will see not only the 2 summary tables, but we will also be presenting the follow-up tables that are individual and that we will be documenting in greater detail governance, manometers, documents, etc. So I'm very proud of the designer. I think that this presentation of the data has been very well done and allows us to see through the mapping process what the current status of the countries is within the region, and this is part of the process involved in trying to achieve this continuous quality improvement growth. And we can see that this will be evolving to the point where we will be able to decide which data to collect and analyze for the purposes of improving our processes as well as the reporting mechanisms that we use. I hope that this was useful information for all of you and that you will share some of your insights regarding this report. We look forward to hearing from you. Thank you.
Wow, genial, genial, genial.
Wonderful. Absolutely wonderful. Natalia, I want to congratulate you because you've done a wonderful summary of everything that we're doing. I hope that you all study this report and that you find some use in it in terms of the main incentive that it offers, looking for gaps and trying to overcome them for better results next year. We want to identify the priorities and how we will be addressing them to progress in 2024. I'd like to talk about two other issues. Remember that this map tries to place in a single space all of the dimensions in which we are working. Some are structural elements, others are process elements, and finally we have results elements. So results will always be a product of the processes and priorities. Now, when we see contradictions between the different areas, and this is a good point to assess, then something isn't working properly. So it can't be that everything is working so badly and we still have very high levels of governance. That's not really consistent. We cannot have poor governance and good levels of coverage and control. So if we look at reality and if we see how you can look at this methodology to conduct assessments of your own departments, provinces, municipalities, or what have you, that will allow you to see over time the progress, the challenges, and the work and actions that you need to undertake to overcome the issues will be very favorable. This is something that we will be sharing with the Ministries of Health, with the PAHO leadership, so that we can all look at what's happening on the ground in a transparent way. And I think it'll be even better because we will be covering each one of the components, right, Natalia? We're going to be explaining in great detail the evolution and the meaning that each one of these elements has. So the countries that are ahead of the others, and we've already mentioned this, they've progressed more than others. We congratulate them. The countries that haven't performed as well are being encouraged to do better. And the new countries that just joined the initiative recently know that they have a long road ahead, but they now see the road ahead in a much more clear and evident way. So we believe that to be a very good thing. So thank you, Natalia. And now we will move on to our next panelist to close this quality improvement issue. So, Angelo, can you introduce our next panelist, please? Yes, we have the honor of introducing Jonas Garces Garcia, who is an advisor on healthcare systems, quality services, and he will talk to us about the quality model that we use in hearts, and he will discuss the policies involved in developing this model. You have the floor, sir. Can you all hear me? Can you see me? Yes, we can. Well, the truth is this has been a very rich process, and my role as an advisor to healthcare systems and services and quality services in particular is to provide insights related more to the system. And it involves a more integrated approach to quality. I think there are many aspects associated with quality improvement. Any methodologies or approximations that I may add will be complementary to what I've already heard so far. Each country has to face its own challenges and address these issues in the best way possible for them. Nevertheless, I have some insights that you may find useful and that may be used to help you progress in a much more solid and consistent way. I think that there's a win-win situation here for all the stakeholders. If I've heard one thing in these 2 days, especially this morning, is that this network of countries and stakeholders are all working with the same objective in mind. They're working at the local context level, and this is very powerful because when we talk about cooperation, technical cooperations and strengthening healthcare systems, we are obliged to make this priority the main issue for our work. I did have a discussion yesterday with some colleagues in the Hearts team, and I did put together some slides that will allow me to convey my message in a clearer way. You can let me know if you can see it.
Sí se puede ver, Jonás, quizás lo pones en... Ah, ahí está.
Yes, Jonas, you can see it. Thank you very much. The first thing that I'd like to share is that prior to the pandemic, in different environments at the international level, there was a very rich discussion, especially in 2018, and this is documented in various publications that were published in 2019, and it addressed how to deal with quality issues in the healthcare system. And we had some interventions with WHO working groups, with organizations here in the US, the World Bank, the OECD, and all of these stakeholders arrived at a set of shared visions. And prior to the pandemic, they highlighted the need to address a new paradigm to address the issue of quality in that sector. The quality, the methodologies, the process work in particular was deemed to be very, very important within the Hearts framework, and it continues to be a very essential component, but it's insufficient for us to really bring about sustainable changes in the quality and the safety of the care afforded to patients. We still need to incorporate a much more systemic approach. We also need to incorporate aspects and features that were previously not included in the services. This involved a number of professional people and quality experts. And by this, I'm referring to governance, the existence of a framework, political will, a regulatory framework, something that could be consistent in supporting the efforts that are conducted at the local level that provide continuity and that are part of a shared vision. This shared vision is also very important. We see here other publications that I've alluded to. This shared vision emphasizes, among other things, thinking not so much about, and I don't mean this to undermine their importance, but to think about the impact to the population in addition to the results. So there is a refocus on centering efforts on improving processes and measuring processes. And this includes 2 decades of work, better visibility for these processes, and that notwithstanding, we haven't been able to see better results. And this is all linked to a number of regional consultations and a document that was approved in a region in 2019 related to quality. And this was part of development that really establishes a classic line of intervention, which involves the entire healthcare service organization. And we were supporting the classical methodologies used in healthcare services, but there was also a clear-cut focus on the work of oversight, governance mechanisms, the existence of strategies, national plans related to quality that are properly aligned in the healthcare strategies, plans, and that have the political will and the strength to be able to develop and evolve as national policy. This is a line that in the quality environment had not been adopted previously. We had multimodal strategies, especially with regard to healthcare facilities, but we did not have a model that involved the national health authorities and other key stakeholders to adopt a more comprehensive approach to any quality improvement process. And it also includes a third strategic axis that addresses in a direct way the issue of financing. And it's stated so very explicitly, as well as the necessary resources. We cannot move forward if there is no subset of available resources. And in many times we took on expenditures that did not add value, and we saw that there were expenditures that had no importance, and we saw a multiplication of the issues involving many different processes, such as the illegitimate use of available resources. And it also involved issues related to human resources, economic resources. And unfortunately, this is a very real situation in many of these systems. So there was a greater focus placed on the importance of these aspects related to healthcare financing and healthcare investment. And the proper management of available resources and the adequate documentation and adequate continuity for this quality improvement process. In the global context, these became much more relevant, and it served as a mobilizing element. And everything was then centered on patient safety, but at the same time, it had a more systemic perspective, and it also included elements that sought to address adverse results directly caused by the healthcare system. When a healthcare system doesn't have the necessary resources to conduct a timely diagnostic for a hypertension case, then we are impacting patient safety because there is a clear-cut risk based on a condition that it is eminently treatable. So at the global level, we established a quality strategy projected from the year 2021 to 2030. And recently, we just presented a midterm report for our quality regional plan. And we have to recognize that it was a plan that was worked with extensive participation by all the countries, and it was deemed to be very ambitious. It had some foundational challenges that we had to address to achieve the goals that we set for ourselves. And I think this was particularly important for hearts and the shared vision. It wasn't just involving the guarantee of quality in processes, but we also needed to see that reflected in the impacts and in the outcomes. The idea was to not just achieve national groups working for coverage and control in the healthcare system. We need to improve these components, and this is a perspective that was deemed to be visionary, and they are clearly outlined in the Hearts proposal. We want to include monitoring, but we also need to keep in mind the eventual outcomes of all of this. I'd like to share some insights regarding what I know and what I continue to learn about the progress in the healthcare systems and the patient quality development team based on what we've been learning about the Hearts Initiative in the Americas. Without a doubt, it's a great opportunity to contribute to a key agenda, which involves strengthening the primary care capacity, and it needs to look beyond the primary care. The strategy implies fostering and promoting better healthcare, earlier interventions, timely interventions, and other levels. There's a fundamental component to strengthen that first level, first tier level of care. There is an objective to progress through window of opportunity that is not small. And I'm going to use simple words to describe something that is not simple, but we wanted to focus the proper monitoring of these particular elements. And we need to strengthen that capability, and we need to never restrict these timely interventions. At the end of the day, when you have a hypertensive patient, you have to assess that patient as a person, not just as an individual. We need to understand that the patient, to a large extent, typically has multiple morbidities and hypertension, and we see that now as an opportunity for Hearts to take the matter into hand and address the problems. So we also need to address this in a multidisciplinary way, understand the roles for each one of the team members, understand the national context, the available resources, and try to promote success stories such as the expanded role for nursing staff. That is key, as we've heard on a number of occasions, but this goes beyond that. The role of healthcare promoters, the importance, underlying importance, and mentioned frequently by Pedro, to incorporate the community perspective. The reality is it is perceived at that level and involve communities so that in the region, the assessment of healthcare services can be properly responding to the real needs and, by extension, advance with the agenda. And we also need to establish a process that is anchored within the Hearts program, but that can subsequently be expanded. We need to recognize this enormous potential that the existence of multinational networks have to be able to share information on similar situations. So this will allow for maintaining sustainability over time if these networks are strengthened. We want to add all of these networks, and the reason is if we have a level of intervention from the operational side and from the networks that are operating, one of the most important challenges is to provide more visibility to Hearts beyond the stakeholders, beyond the people that work on a day-to-day basis with Hearts. It would be very important for us to align the Hearts interventions in the different countries with the national health plans in those countries. And for that purpose, you need visibility. And if you have a plan, a strategy for national policy, then you will bring about more visibility for the program. You need to know more about what you're doing. Now, when we do technical cooperation with different countries, there's a certain specificity and not verticality for this priority. And we need to generate the necessary conditions and inertias to ensure that these projects are able to achieve sustainability over time and are able to connect to healthcare organizations. And the authorities and leaders here are the ministries of health and other high-level stakeholders. It's not just hearts as the focal point, and this is a continuous challenge for us. We need to shoot higher to be able to align our interests with those of the national interest. So this framework needs to be consistent in terms of the implementation in the various territories. At the end of the day, quality occurs in the territories. And territories set the conditions of political context, cultural context, barriers to healthcare services. And we need to understand this really well to be able to move forward with sustainable projects. Those of us who work in the quality arena have had many experiences whereby we have successful projects that do not withstand the test of time. They don't survive because something changed in the political administration, or something changed in the financing or funding mechanisms, or something changed in the priorities set by the administration. And this is a very important challenge to be able to set and establish these initiatives in such a way that they can permeate all the organizations in a structural way. In essence, this is all very complex, not at all easy. And again, this is not bad news. We don't have a magic wand to achieve what we want. We do have powerful tools available. Nevertheless, the establishment of a sustained change in the healthcare system requires greater permeability in the structure of these institutions, that all of this is properly linked to funding and financing mechanisms in order to ensure that these programs do not disappear. We need to get away from earmarks that depend on very particular contexts.
Based on the discussions and what I have heard, this is something really clear with what you have shared. And then I will be inclined to believe that the 33 countries that have this commitment and all those other countries will continue to build upon this. I would like to reiterate the need to have a territorial approach, to have a successful operational implementation of HARTS within a perspective of interculturality. And because we, of course, are all experts, but we have to really think of the populations that do not have as much information, and we have to establish a dialogue with populations that we want to help, because if we don't do that, we will not be able to advance. I always have a certain perception of expectations of having magic wands to be able to immediately solve all of these problems in counseling and facilitating the creation of bridges, giving visibility to different topics. Next week, we will have an important event with our director, Dr. Barbosa, and together with representatives from the World Bank and the Inter-American Development Bank. We will have a regional forum in Montevideo, Uruguay, and we want to make sure that these financial actors plus PAHO will start activities of financing for primary healthcare in the Americas. And then your work is directly related to these initiatives. Therefore, I would like to insist upon the role that we have as health agents working in health, working in quality improvement. We have to take advantage of this opportunity to give visibility to our work and to incorporate other actors and other visions in the vision that we're promoting. We have to learn from each other. So these were my brief reflections. I wanted to share this with you. Thank you so much. Thank you so much, Jonas. This has been a tremendous opportunity. We still have a long road ahead. We have to continue to learn about the synergy about national policies and concrete projects for quality improvement, because all of these is complementary. We have common challenges, as you said, but we have to keep on going ahead with the narrative. Hearts is when you think that Hearts is a vertical program, it is not. It's not a vertical program. So we have to see how we can continue to advance, because it is important to have a good platform for the health services. Because during this seminar, we have discussed that Hearts cannot be something parallel to the health system. It has to be incorporated into that system. And that's a very hard stone to throw. So we have to really consider what you have said, Jonas. Something that you said is 100% together. There are many successful projects that fail in the long term because they are unsustainable. Yes, that's true. Yes, I can also say that there are national policies that never generated successful programs. So we go hand in hand in this. So we have to have a good basis on the platform of the healthcare system, the quality of that healthcare system, the strengthening of the structures of the first level of care, primary health care, to be able to put on top of that elements that work. And what we do in public policy is that sometimes we just project general approaches, but we do not give concrete solutions to the problems. So this requires a global and strategic and systemic approach, together with concrete actions that allow us to move the wheel until everything works okay, in harmony. So for that reason, in addition to thanking you, Jonas, we will have more opportunity to talk. We have to establish a synergy here. Yes, I believe that this is a well-conceived strategy when we talk about the different approaches to different problems. We're not only emphasizing the territories, but we have not going to the macro level, we're going to the micro level. to see what goes on in the communities. So now we will go to the next topic, which are the priorities for 2024, to see if this is consistent with what we have discussed. So without losing any time, I would like to ask the panels and all the participants to be ready. This is the last session before going to the work group. Please write your experiences in the chat. Ask questions. What is transforming hearts? Not all the countries have determined this. The countries cannot say what is being improved with hearts. Even in the countries that are beginning to implement hearts, has anything improved? So I will just mention the priorities for 2024. Everything is summarized. Everything will be clear to you. Next one, please. So the first one shows something that is clear. Hypertension is the gateway to the heart system, but that doesn't mean that we are technically confident in this. This is not a vertical program, but it's not centered on hypertension only. So I want to say cardiovascular disease is the #1 killer. More people die from cardiovascular disease from any other cause. So hypertension means more than 50% of cardiovascular disease. If we don't understand this, we cannot go ahead. So hypertension affects many organs, many systems, and here in yellow, I have underlined the most frequent diseases. Heart disease, cerebrovascular disease, kidney disease, dementia, heart failure. All of those diseases have to do with the treatment and prevention of hypertension. If you have a headache and you take a pill for your feet, no, it doesn't work. You have to take the appropriate medicine, because that's the burden of mortality. This I want to make clear. We have to focus on the health system. The health system is non-functional. The health system has to work better to be able to change things. This type of discourse will blame the patients because the patients do not follow the treatment or the doctors do not follow the clinical practices. The problem is that the system doesn't identify those people who have hypertension. They do not identify them timely. They cannot say whether they are taking the medicine. So what we have had in the past few years is that after years and years of death reduction, we have to count the number of health interventions and the number of avoidable cases in terms of years of disability, in terms of what we have had in the past few years. Mortality is diminishing at a slower rate. So we have to consider life expectancy. There's an urgency to do things fast, to be clear. So this is clear to us. So the requirements for care are enormous, and all of those have to really work on this fast. In the case of hypertension, we have a key example here. If you have lower levels of diagnosis, lower access to clinical the care. So this is a proxy that we have, the ones that appear here in red. This is concrete. The number of diagnoses is very low. The awareness proportion is low. And here, we reiterate this. Why do we have this? We have a correlation. We have a strong inverse association between HDN control and IHD and stroke mortality. This is what is happening in the health services. In other words, the countries that have better control of hypertension in the population, they have lower mortality and stroke events. For every time that the control of hypertension is increased, you have a reduction, an equal reduction in stroke mortality. So this is a key intervention. We have to identify this among the thousands of problems, the thousands of priorities that we have here. We really need to know what is the winning game here, to be able to model what we can do in the health system, just to make sure that we can open the door to the care of cardiovascular disease. So things being that way, when we look at this again, we have a really important element. Here is a clinical pathway. Here is a picture. In many cases, CVD risk is the point of entry to the health system, just by checking blood pressure in a precise way. That is the first step to preventing the domino effect. The patient goes and gets a diagnosis or doesn't get a diagnosis. So this is the first step. Hypertension, prevention of hypertension and treatment of hypertension is the most effective measure than any other intervention. So that's the prevention of cardiovascular disease. Cardiovascular disease can cause many chronic conditions. Control or hypertension is essential to lower risk. Control of hypertension is essential to avoid the progression of CVD disease. And this control has a significant effect on mortality. And the improvement of hypertension control and adequate control diminishes the number of events and the number of deaths by CVD and for heart disease. So the non-pharmacological treatment also has included multiple risk factors, and hypertension management is a model for other NCDs management. So hypertension management is a comprehensive and integrated clinical approach. So this is essential for us, all of those who are in this line of work. So what do we have to do? Here, we have to really target these figures. 80% of diagnosis, you see if you follow me, 80% of diagnosis and treatment, 80% of control among treated people. And so with this, we will always be able to control only 50%, half of the people who are hypertensive, because the current figures are the ones that appear here in the lower part. And so this shows a problem of access in the health sector, the measurement, a gap in measurement of health system. So when the system captures and diagnoses these people and can put them in control and treatment, everything is controlled by the fact that when we measure hypertensive patients, we put them in treatment, we spend time in services, but we only control from 50 to 60%. So this is at the regional level. So you can just go and see what the situation in your country is like. So this is just a suggestion. Just have this exercise. These are just examples for priority. Just go and fill out the lower part of this chart regarding your country. So that's what we have to do. Which is the first priority? The first priority for 2024 is to scale up and integrate hearts in all primary healthcare centers. We hope that at least in more than 60% of the primary healthcare centers, we hope that we will implement HEART by December 31st, 2024. We have a group of countries. We are closing the year with 10 countries. We are hoping to increase the number of countries that have their health services integrated here by next year. So this is what we have to do. This is what we're lacking right now. These are the obstacles to advance. So there are 4 priorities. This is the number 1. Number 2, we have to institutionalize and fully implement the HEART's clinical pathway in PHC networks. Everything that this implies. And here in yellow, I have just underlined the blood pressure cuff topic. I will not go into details. This doesn't work alone. This has to go with the review of blood pressure and then training, adequate training of first personnel. This is the whole package. So we have these measures. If we do all this, if we have only one of these points in place, things will not work. And the other thing is drugs. We have already given a good step in this direction. So we have to improve the drugs that are included in the national formularies. The drugs that are in the national formularies, in many cases, did not allow for control of blood pressure. So we have to put this up to date. Some of these were obsolete drugs, and this is something that we are changing thanks to the joint effort of the countries. So the topic here is institutionalize. This word doesn't mean that it doesn't have to do, in this case, the clinical pathway continues to be a therapeutic framework, but has to be the instrument for integration of all of these efforts. But we have to look for institutional ways to be able to implement HEART. So third priority, the third one is implement and scale up the HEART's QI approach in PHC centers that are implementing HEARTs. Regarding the governance structure, if the governance structure offers the basis for stewardship and governance, the system tells us what are the improvements that you want to do to the processes, or what are the processes you want to improve. So definitely we have a lot of room for error, but yes, if we have headaches, we take medicine, but we have to really see what are the drivers here. And then those are the health centers. And we hope that 1/3 of the centers that are implemented HEARTs, I hope they can display all of this. Look what has happened in El Salvador, in St. Lucia, in Cuba, and in the Dominican Republic. So we have 5 examples that are centered on working with the political will of the country and to have HEARTs as a strategy that is incorporated in the healthcare services and to guarantee validated blood pressure cuffs and to make sure that you have all the instruments to improve the levels of detection. And what are the proper alternatives? And then the fourth priority is that we have to improve data quality and reporting on implementation in all primary healthcare facilities of HERTS implementing countries, because if we do not know what these data are, that's bad policy. If we do not have this data, we will not be able to forge ahead. So I like to reiterate that if at least 90% of primary healthcare facilities, if we do not have those facilities implementing control, we have to really say that proxy, that the coverage is a proxy or some kind of factor that improves access to health care. But we have to think of the capacity that a health system has to complement all of these measures. So these are the 4 priorities that we have for 2024, and I like to share them with you. And then when you go back to your countries, you will have to think of how we can go ahead with these 4 priorities. Number 1, to improve the number of sectors implementing the HEARTS model, to be able to cover 100% of the centers. Number 2, institutionalize and fully implement the HEARTS clinical gateway. Number 3, implement and scale up the quality control. And then number 4, improve data quality and reporting, because this is a central, occupies a central place in the model for improvement of quality of care of a group of diseases. Just see that the clinical pathway for hearts is specific because it integrates all of these components, and we have very good examples of this, and there's a number of countries that have already advanced through the clinical pathway, that are incorporated, that are talking among themselves, that where there's synergy, but where problems of the people and communities are identified. So this doesn't mean that the program is centered on disease. We just have to find a focus where we can see change in a more radical and clear way. So these are the HEARTS priorities, and now I would like to invite you to discuss this in our next session. So we hope that each one of us, you have a link that will take you. We were going to meet in the different countries. We have a Speaking Caribbean group, and then one group for Central America, Mexico, one for South America, and one for the English-speaking Caribbean group. Right now, you have the link that takes you to each room. Jenny or Angelo, please turn on your camera and give instructions to the group so that we're not lost. I would like to thank you is that please write in the chat about your experience, how you consider this workshop, what were the main topics, and then please reserve other comments for the discussions that we will have in the work groups. Thank you, Pedro. Yes, next, as mentioned by Pedro, we will have group work, and then you will see the 3 links for access to these rooms. I would like to ask my colleagues who are facilitating this exercise to make sure that you are in the correct place. In the South American group, we have Andrés Rosende and Libardo Rodriguez. So if you see Libardo, then you are in the proper group. Then we have for the Spanish-speaking Caribbean group, Mexico and Central America, we have Natalia Parra and Jenny Rodriguez. Thank you. You see Natalia, and then for the English-speaking Caribbean group, we have Cynthia Lombardi and myself. So we will not be coming back to the plenary room. We will finish our conversations in the groups, and we would like to invite you to go to these rooms with the links that you have there. We will be waiting for you there. So right now, the countries have the opportunity to put their messages in the chat. We will give them 5 minutes. We will begin at noon. But now your final comments in chats, greeting to your colleagues, the impressions about the workshop, anything that you want to comment on. Mexico is going to stay in the Central America. It says Hispano, but South Americans are Spanish too. But okay, it says Dominican Republic, Mexico, South America in the other group, and the Caribbean, English-speaking Caribbean in another group. Thank you so much to all of that. Thank you. So we will see you in your respective rooms. Thank you to all the participants here. Angelo, thank you so much for moderating this. And thanks to all the colleagues that we have here today. Thank you all. And please know that all of you, the ones who register, will be receiving your certificates and also all the documents that we will be publishing in the next few days. That's the manual, the quality instruments and tools, the compendium of clinical instruments, and the heat map presented by Natalia. Thank you so much. Thank you. We will see you in the respective rooms. Thank you. We will just change. Thank you.